On behalf of the National Eczema Association, I'd like to welcome you all to the presentation, Getting a Grip on Hand and Foot Eczema. I'm your host, Ali Loisel. Our presenter today is Dr. Raj Chovatiya. Dr. Chovatiya is a clinical associate professor of medicine at Rosalind Franklin University, Chicago Medical School, and is somewhat recently founder and director of the Center for Medical Dermatology and Immunology Research in Chicago, Illinois. His clinical and research focus includes the intersection of cutaneous, immunology, and inflammatory disease. And with that nice long introduction, I'd welcome Dr. Raj Chovatiya, and I can hand it over to you.
We're going to get started and not waste any time. So in about the amount of time that we have here today, what I want to do is maybe spend about 20-ish minutes or so going through what I thought was my version of talking about hand eczema mostly, and a little bit of feet in there, and I'll explain why I say it in that second. And then I'd love to leave plenty of time at the end for any discussion between myself and Ali and any questions that you guys have as well. So we're going to be putting a handle on hand and foot eczema. These are my disclosures for work I've done in the space, a good chunk of it actually related to eczema and even hands and feet as well. And I really want to sort of jump into talking about hands first, and we'll loop back into feet for a moment. But part of the reason we're focusing a bit on hands is that the preponderance of information, research, epidemiology, burden analysis, even specific trials and treatments has really been focused on hands. And in particular, chronic hand eczema. And so there's many folks that are probably tuning in or that you know in the larger eczema community that talk about having chronic eczema on the hands. But what is chronic hand eczema or CHE? It's a term that is a little foreign to most of us in the US, but very commonplace in the Europe and the rest of the world. And the US is catching up a little bit, but this has really been pushed forward by a lot of occupational research from other parts of the globe. When we say chronic hand eczema, we're really referring to terms that are used a little more commonly here in the US, hand eczema, hand dermatitis. Those are all probably what doctors might say a lot more commonly when you see them. And what they're really referring to is inflammation of the skin of the hands and the wrists, usually showing quote unquote eczematous dermatitis. And so you guys are savvy, you know, eczema is usually referring to a pattern on the skin that oftentimes consists of redness and scaling and swelling and excoriation, even erosions. In the case of hands, vesicles, tiny fluid-filled bumps, and smaller bumps that we call papules, hyperkeratosis, which is the fancy word for a lot of excess scaling and thickening, are all things that you might see as well. And they're typically accompanied by itch and skin pain, symptoms that you're probably quite familiar with in the world of atopic dermatitis. And chronic hand eczema can coexist. We'll talk about that in a moment. But in the case of hands, oftentimes it's pain that even outweighs itch in terms of how much people are bothered. As you can kind of see in this picture on the top right, having one single fissure on your finger can really be quite annoying and quite painful. And so by definition, this might surprise some of you, but chronic hand eczema is really just hand eczema that lasts for at least 3 months or relapses at least 2 times in a year. By that definition, you may think back on your life being like, oh, I've probably had CHE a time or two or intermittently throughout my life. A really common story, people who become brand new parents or change jobs in some way where there's a lot more hand washing and work with hands that others didn't exist before can probably get a diagnosis of CHE slapped on them. So the in-year prevalence from year to year can actually change even in someone's lifetime in terms of them getting the disease itself. Chronic hand eczema can look a lot of different ways. So even in this slide, I chose some of these pictures across a very nice article from the New England Journal of Medicine, as well as DermNet NZ, which is a great repository of photos online, to show that these are all referring to the same entity. Chronic hand eczema is a little different than atopic dermatitis and other diseases in that it's a bit of a bucket diagnosis because there's a lot of different etiologies that go into this singular terminology. It shouldn't surprise you guys as well that this is an immensely burdensome condition, and more on that in a couple of slides. Now, when thinking a little bit about chronic hand eczema, it characteristically presents with usually a combination of physical findings. So you can see here that you have erythema or redness, you have scaling listed there on the hands, you have edema or swelling over there in terms of that top image, vesicles, as I mentioned, small fluid-filled bumps. You can get smaller bumps called papules, hyperkeratosis, heaping up of scale in these areas you can see of the palmar surface, fissures. Oftentimes, these breaking open areas of skin right on the fingertips are really, really, really aggravating, very painful and hard to heal. and even erosions or skin loss or maceration, oftentimes in the interdigital spaces in between the fingers as well. Now, chronic hand eczema is actually a pretty inclusive diagnosis, and it actually includes a lot of different forms of hand eczema. So you may have seen a healthcare provider at some point in your life, and somebody said, you have dyshydrotic eczema or vesicular eczema. You have hyperkeratotic hand eczema. You have atopic dermatitis mainly involving your hands or atopic hand eczema. You have an allergic contact dermatitis, an irritant contact dermatitis, even nummular eczema, nummular dermatitis. As it turns out, all of these different etiologies and presentations, they all actually fall under the bucket of chronic hand eczema. And part of the challenge with really understanding chronic hand eczema is that there are different etiologies based on both pathophysiology as well as clinical presentation and actual clinical risk factors as well too. And that's kind of the cool thing about this disease compared to others, let's say like psoriasis, which are a little more straightforward and linear. This one actually buckets even more than just atopic dermatitis. So it really is a very inclusive disease, and frankly, almost the lumper's dream in the sense that there isn't that much differentiation needed to really have somebody make this distinction. Part of that challenge also comes from the fact that it's really hard to pull out any one of these specific conditions away from the others, as there's a lot of things going on in the hands. If you think about it, you work with your hands are exposed to a lot, you do a lot throughout the day. And so there's a lot of different things that could be driving what you see on the hands. So as far as chronic hand eczema, it's a pretty common inflammatory disorder. So in this case, the point prevalence, or basically if I was just choosing any one single point in time across all of adults, somewhere around 1 to 5%. But if you actually look in a 1-year span, it's thought to be around 10%. And you could think about sort of how individuals might have different activities they're doing through a year, potentially, differences in terms of what their exposures might be like, weather changes as well too. During certain months, people may wash their hands more than others. And, the problem is that some of these numbers may, in fact, actually be underestimates or overestimates, depending on which side of this argument you fall on. In the case that milder disease oftentimes is used to make these claims, but then also at the same time, sometimes people aren't getting the right diagnosis. A lot of these numbers that we have about this disease really are driven by Europe, as I mentioned, because Europe has a lot of socialized healthcare. Therefore, there's a lot of larger registries that are taken from major payers, and thus people are able to track these things a little easier. And in medicine, particularly in Europe, occupational medicine is much better established as an important driver and really researched area as far as healthcare burden and money goes in terms of governments. And so chronic hand eczema is the most common dermatosis we see from an occupational standpoint for sure. But it also occupies an important role across all occupational disorders too, even beyond the skin. So in terms of the lifetime prevalence of chronic hand eczema, there's probably several people on this call that have had CHE at some point in their life. It's estimated the lifetime prevalence is maybe somewhere around 15% across your entire life. The occupation-related cases usually are the ones that tend to be most severe. As I mentioned before, it's the most common occupational skin disease. And classically, the teaching goes, people who have a lot of contact with external substances or a lot of wet work are going to experience this. Hairdressers, nurses and healthcare workers, bakers, cooks, people in the print and typesetting industry, cleaning, manufacturing, people in the culinary world. A lot of those are the ones that are having chronic hand eczema issues because there's a lot of exposure to allergens, irritants, and even just background skin disease too, that we know is very common in this population. It's also more common in women versus men, maybe up to about twofold, particularly in young women. Now, it's been sort of hypothesized there's a few reasons probably for this. Some of this probably has to do a little bit with just gender roles and imbalances in society more than hormonal differences. It's thought that a lot of this is driven by the fact, given that there's probably a higher rate of wet work amongst the female population versus males historically. And that's probably where a lot of that imbalance comes from, as opposed to specific biologic, genetic, or hormonal reasons. I mentioned a little bit about the burden of this disease, and I want you to just kind of pause and think about your hands and really reflect on the fact that if you couldn't do your day-to-day work or your hobbies or just simply take care of yourself with your hands, your life would be pretty miserable. And it's part of the reason why there's actually a lot of work, productivity, and activity impairment that individuals face as a result of this disease. And I chose this graph not because I want everyone here to be able to tell me what HECD and DLQI stands for, but rather on the x-axis, you're looking at going towards the right people having way more burden in their life from the disease. And on the X and the Y axis going up and down as you go up, this is more and more severe disease. And you can see that there's a pretty good relationship between the more severe your disease is, the more burden you're going to report in terms of the skin disease having an impact on your life. And some of that comes from your reduced ability to do work in an occupational setting. People actually take long-term disability. This is a really important claim that's filed for people being disabled from their work, given that they need their hands. Talk to any dermatologist and they'll tell you that they've seen individuals coming in trying to oftentimes get work letters, or even somebody to sign off on a disability claim because they simply can't do their work. I've had nurses and scrub techs over the years. I've had people in the culinary world over the years. I've had others where they just simply cannot, based on the condition of their hands, go about their day-to-day business, because this tends to be a chronic recurrent disease as well. There's a lot of elevated financial costs to manage chronic disease too. In the case of mental health, unsurprisingly, with a lot of the work that's been done over the years in atopic dermatitis, particularly funded and in conjunction with NIA and other organizations, we know that in the case of CHE, it's pretty similar. There's a lot of increased rates of distress, anxiety, depression, suicidality. And again, it's really driven by a lot of different elements of thinking about life burden that individuals have too. So what are the causes of eczema of the hands? And we'll get to feet in just a moment, but I want to focus on hands for just a second here. With hands, it's a combination of endogenous and exogenous influences. So we know that in the case of hands, there's the environment, there's allergens, there's irritants, there's internal skin barrier dysfunction that you may already have. There's immune dysregulation that could be existing in somebody that has known atopic dermatitis. There's cutaneous microbiota changes that can be both as a result of the external environment and also intrinsic too, in terms of people that have atopic disease. And in fact, atopic dermatitis, the most common chronic form of eczema that we think about when we say the word eczema, is a key risk factor for this disease. About 1/3 to 1/2 of individuals with chronic hand eczema can be considered atopic. And about 2/3 of individuals with hand eczema may have a history of childhood eczema too. And so it's important to note that every time somebody comes in with eczema on the hands, it is not a guarantee or a requirement that they have atopic dermatitis. The diagnosis doesn't have to be atopic dermatitis. They may not have a history of atopic dermatitis, but a personal and family history of atopic dermatitis does tend to be more common in people that do have hand eczema, particularly chronic hand eczema, especially more so in the adult world than the pediatric world, given that there's a lot more hand use day to day that adults are going to have than kids. We generally also know that of the atopic diseases, having a history of atopic dermatitis is a stronger risk factor for developing chronic hand eczema, more so than asthma or allergic rhinosinusitis or eosinophilic gastroenterologic disease, conjunctivitis, etc. Now, the majority of chronic hand eczema is driven by environmental influence. I know that, again, I just spent all this time talking about atopic dermatitis, but it's really, again, a smaller part of it. The distinguishing feature really of this disease is so much of it is about what you are experiencing in the real world in terms of soaps, in terms of detergents, in terms of water, wet, dry cycles, in terms of irritants, in terms of weather, humidity, temperature, etc. The presence of underlying barrier dysfunction in the case of atopic dermatitis, though, again, you can understand why you might be more susceptible as well. The most common external cause of chronic hand eczema is typically irritants or toxins. And so what do we mean when we say irritants or toxins, as opposed to a true allergen? Allergic contact dermatitis typically means that your body has a characteristic and repetitive immune response, a memory of some item that you're being exposed to regularly that you mount a very specific response to. And the only way for us to really formally rule that out is a procedure called patch testing, where they draw a big grid on your back, stick a bunch of squares there, and then essentially tell you that, okay, you're reacting to this one thing. Irritants are a little more promiscuous in the sense that irritants and toxins are really anything that generally just causes some degree of skin damage, stripping of lipids on the skin, increasing permeability to moisture and water, and thus activating the immune response somewhat non-specifically. A good example would be doing a ton of hand washing repetitively over and over again. You're not developing an allergy to something specifically. It's just the constant use of chemicals in soap and water over and over again is going to be enough to dry you out and drive hand eczema. So it's that type of external exposure that is really more common. And allergic contact dermatitis is important, and we'll talk a little bit about how a dermatologist might look at that. But it's a hard one, even if you detect a very specific chemical you're allergic to truly eliminate. And for those of you guys that have allergic contact dermatitis out there, you're probably thinking in your mind, following a safe list is no easy feat. And just given how our hands are involved in a lot of different things, it can really be very, very challenging. So the bottom line is that in clinical practice, most cases of chronic hand eczema are multifactorial, and they're not specifically pure. We have a lot of different reasons why someone may have hand eczema. In most cases, they're all happening at someone at the same time. So I mentioned that there's a lot of different risk factors, even beyond atopic dermatitis. And this is just kind of a little lollipop diagram showing that there's others, right? You could have age of onset, intrinsic mutations that make people more likely to have dry skin or eczema. We talked about contactants. Cold and dry weather can be a precipitant. Indoor humidity, what you do for a living. Interestingly, there seems to be a relationship between tobacco use, but that might be related to just overall health status. We have lower educational level, stress. This is just a sampling, again, largely from the European world, about risk factors associated with chronic hand eczema. So I know I've spent a lot of time talking about the hands, and I want to take a sidestep, pun intended, to the feet, just for a moment before we kind of go back to hands. And part of the reason why is that if you end up doing a deep search on this, the literature on feet is much thinner, in part because most of what I say applies to hands applies to feet as well. There's just overall less research specifically focusing on feet, as there's a lot more occupational and disabling burden associated with the hands. But the considerations are pretty similar, right? Irritation is probably, by and large, the number one thing that drives chronic eczema of the feet. And this is typically because of chronic sweat, moisture, rubbing, pressure, friction. The fact that this is an area of the body that is consistently experiencing your body weight, movement, it's usually trapped in socks and or shoes or boots as well. You're creating a perfect nidus for really irritating your feet, especially if you have intrinsic atopic dermatitis as well. And this can be a primary driver for some patients, but again, it's often secondary to usually more irritation. Allergic contact dermatitis is an important consideration, in part because when people have issues with their feet, what do they do when they come in to see me? They say, well, doc, I used this hydrocortisone, but then I used these two types of lotion, then I tried this antifungal, then I tried this other antifungal. People end up trying a lot of different products on their feet, but the big difference between hands is that they kind of go about their business in terms of sticking their layers of socks and using the same shoes or boots over and over again. So you end up actually impregnating a lot of the stuff around your feet with the chemicals that you're using. So in addition to the topical cycling, you're getting exposed consistently to a lot of chemicals in a very confined space where you're simply just pushing that stuff onto your feet. So that's the one main difference and consideration that you think about for feet that don't exist for hands. And so it's the reason why anytime a healthcare provider might say to rotate your shoes, take a break from wearing them, air out your feet, try to keep the moisture down, make sure you're drying relatively completely, avoid sort of using tons of different things. That's the reason why. Beyond that, in most cases, just about everything I say applies for hands and feet. There aren't, unfortunately, very specific therapeutic development or approvals for feet alone. They usually are in context with hands, or it's just hands alone. Again, given the fact that hand eczema is overall more common, but also has this disability burden associated with occupation that just hasn't been shown quite in the same way as feet as well. So I wanted to make sure that feet got their due. So kind of going back to chronic hand eczema for a moment, and like I said, these frameworks and papers, again, can be applied to feet, but in the case of CHE as an entity, there unfortunately is no CFE or chronic foot eczema. You can think of chronic hand eczema as being broadly classified into etiologic and clinical subtypes. Big fancy words that refer to the driving features and what you see on the skin features. So in terms of these etiologic subtypes, as I mentioned, most patients have a combination of more than two of these things you see on the screen: irritant contact dermatitis, atopic dermatitis, allergic contact dermatitis, and an uncommon rare protein contact dermatitis or contact urticaria. Oftentimes, this is seen with responses to specific, more complex proteins. A great example is people who are fish handlers. Because of certain enzymes in fish can develop chronic urticaria, specifically repetitively on the hands, that can drive eczema. But that is an etiologic subtype. These are things that can drive the disease itself. Any one of these or combination of these or all of these can be found in somebody that has chronic hand eczema. There's also major clinical subtypes too. And again, this can interface with any one of those etiologies we talked about. People can be super scaly and rough in the case of hyperkeratotic hand eczema. They can have little blistery tapioca pudding-like bumps on their hands with fluid inside. That's acute recurrent vesicular hand eczema, or what people sometimes call dyshydrotic eczema. Pulpitis, inflammation of the fingertips. That's another fancy word you can impress your friends with and maybe win some money on trivia if that comes up. And then nummular eczema, or essentially having round patches, almost that look like psoriasis sometimes, more often on the backs of the hands than the actual ventral and palmar surface. These can all coexist. And to make matters even more challenging, just because you have one or more of these features, it does not predict the etiologies that we talked about. Just because you may have irritant contact dermatitis, allergic contact dermatitis, atopic dermatitis, it doesn't predict how this is going to look. And then if we take a molecular standpoint based on whichever arm of the immune system is activated, in chronic hand eczema, that doesn't specifically reflect what you're going to see on a clinical exam. And so it actually is a very heterogeneous disease. Heterogeneous being a big fancy word, meaning that there's a lot of different things going on. You see a lot of different things. There's a lot of different stuff bubbling under the surface. And so it's what kind of gives us a lot of challenge when it comes to treatment. Now, how would somebody go about trying to diagnose and treat chronic eczema of the hands? Well, usually, it's going to be the standard. I'll talk to you. I'll take a look at what I see. I'll think about what you're getting exposed to in life. And in most of the world, actually, there's a big push for having everybody to get allergic contact patch testing. If anyone out there has ever had patch testing, you'll note that this is not necessarily a very fun procedure. You can't shower for a week. You're going to put a whole bunch of stuff on your back. You have multiple visits in 1 week. And frankly, even after you finish that patch test, you may not have any pertinent positives, or it may not be clear if anything there is something you should avoid. And even if there is something that you have to start avoiding, it may not fix the problem, again, given the fact that hand disease is usually multifactorial. So it's one reason why there's been a lot of questioning of whether or not we should be more selective with this approach or it should be more universal. There's the practical nature too in the US. It's just really hard for sometimes people to get patch tested or find someone who's going to do patch testing. And there's the economic burden too. So it is an open question about whether or not that is a practical step for everyone in the US. But generally speaking, beyond that, this is mainly all going to be what we say is clinical, talking to you and seeing what I see. There aren't really any blood tests. A biopsy is often not helpful, so it's not specifically recommended unless you're trying to rule something out. Biopsies often show mixed features, and they're not going to tell me all that much. A microbiology test or a culture, unless I was very specifically concerned you had a fungal or bacterial infection, and that would only be in a very rare circumstance if you had some crusting that would seem like bacteria, or maybe you've used steroids on your hands for a long time without much response, and you've created a happy place for yeast to grow. You're really going to make your diagnosis based on everything that you tell me and everything that I see, plus or minus some of these diagnostics. And so the overall approach is pretty similar to one that you might recognize from atopic dermatitis, where usually we're going to have a chat about good skincare, avoiding or reducing trigger factors, doing skin protective measures. I talked a little bit about what that looks like for the feet. For the hands, it's a similar thing. We'll talk about bathing and soaking, the whole soak and smear method, patting down, putting an inclusive moisturizer, especially at nighttime, and then maybe putting on some cotton gloves or socks or anything to really keep that in place. The next step up is going to typically be milder, medium, and stronger topical corticosteroids or topical calcineurin inhibitors like tacrolimus or pimecrolimus. Then people might start going up into more potent therapies. In the US, there are no approved therapies for chronic hand eczema. In the rest of the world, there is a medication called alitretinoin. It sounds a lot like isotretinoin or Accutane because it's in the same family, but it's a different medication. It's an oral retinoid, so it's a pill that has a lot of side effects. Headache and nausea is really common with it, but it has reasonable data for people with a very specific type of hand eczema, the super scaly rough kind or hyperkeratotic. Beyond that, we end up having to go off-label for a lot of our patients that are not responding to topical steroids and similar medications. So that would include some of our big gun medications that are going to suppress your immune system, methotrexate, cyclosporin, or mycophenolate. We might think about atopic dermatitis medications. They're not specifically approved for this condition, And I just told you that it's a multifactorial disease, meaning there's probably some contact dermatitis, there's probably some irritants, there's probably some atopic dermatitis. So there's no guarantee that they're going to work for everybody either. But for people that specifically have atopic hand eczema or atopic foot eczema or atopic disease, they can be effective. So that would include approved topical medications like topical ruxolitinib, for example, approved biologic medications like dupilumab, tralokinumab, lebrikizumab, or nemolizumab, or thinking about oral medications like abrocitinib or upadacitinib. All the different biologics, JAK inhibitors, and topical small molecules you might think about using for atopic dermatitis in other body sites. But by and large, this hopefully highlights to you a problem. We have not specifically tried to encourage pathway and development and understanding of targeted medications for a complicated disease that is multifactorial, like chronic hand eczema, and like I mentioned before, again, chronic eczema of the feet to a certain degree. But I will sort of tail all this off and stop talking to tell you that there's good news ahead. We actually have, hopefully, going to have our first approved therapy for chronic hand eczema in the United States. There is a cream called delgocitinib. Delgocitinib is a pan-JAK inhibitor. What does that mean? It's a small molecule that inhibits multiple different signaling molecules that are important for immune-mediated reactions. And unlike our oral JAK inhibitors, like upadacitinib and abrocitinib, which really try to push the idea of being super selective for one or two of these, this particular topical medication has very little penetration beyond the skin and is very targeted to work across multiple proteins in this family. That means that for a disease like chronic hand eczema that is naturally quite heterogeneous and multifactorial, it actually biologically makes a lot more sense. Safety data looks really, really promising. It's actually been approved in the rest of the world. So Europe had an approval actually last year. And we hopefully will be on track for an approval, if we get lucky, let's say maybe later this summer potentially, and this year, hopefully. So the new drug application for this cream was accepted by the FDA last September. And so hopefully we're looking at an approval this year, which I think will be really, really exciting. And my guess is that it's probably going to be positioned after people have tried topical corticosteroids. We're all familiar with dupilumab as a biologic therapy. That's an injectable medication, blocks IL-4 and 13, which are two soluble signaling molecules that are really important for atopic dermatitis. There was phase 3 hand and foot atopic dermatitis data published in 2024 that led to an update of the label for dupilumab. So it specifically mentions it's approved for atopic dermatitis, including AD of the hands and feet. It's a specific isolated scenario, and I think a lot of people have used dupilumab off-label for general eczema of the hands and feet, but it's generally most effective when it's largely driven by atopic dermatitis. In the case of ruxolitinib cream, the topical JAK inhibitor that we have at our disposal that's currently approved for atopic dermatitis and vitiligo, this is a more specific acting JAK inhibitor in a topical formulation. It is approved for mild to moderate atopic dermatitis, and thus people have used it off-label on the hands, specifically for CAG, quite a bit in the real world. We've seen hand eczema data for it, not specifically in a population of people that are all comers for chronic hand eczema. It looks like it might be promising potentially, but it's not specifically planning for trying to get an approval for this condition, chronic hand eczema. This is just some images taken from the clinical trials for delgocitinib. I thought that this was really remarkable as well in terms of taking a look at week 0, week 4, week 8, and week 16, and seeing how these numbers really dropped in terms of people having itch, pain, as well as quality of life disruption. And you don't need to know much about these scales to see those kind of drop, but also was really stark to see what this individual started at in terms of their severity and what they moved down to at the end of this treatment period. So it's definitely a treatment that I'm very excited for, and one that I have many patients in mind that hopefully might be a good fit that are dealing with a lot of issues on their hands. There's no specific plan in place for foot eczema. Like I said, smaller population. Now, there's no specific scores and tools developed for this. I imagine there's going to be some off-label use in the real world for this medication on feet. So we'll probably actually learn a lot more about eczema of the feet if something like this is available, given that people are probably going to use it for both hands and feet as well. So we recently wrote a paper, this literally was just published last month, talking a little bit about my practical approach to chronic hand eczema. Most credit goes to two wonderful fellows who co-authored and shared first authorship of this paper, Sophia Mensi and Soya Maher, two amazing medical students who are taking time to work with me. And we really tried to put together what our approach to chronic hand eczema should look like to alleviate as much patient burden as possible, we suggested that really after taking your good history and physical and trying traditional topical therapies, we should be much more selective about patch testing and not make people wait around for patch testing that may or may not happen or be that helpful. Really be judicious and choose the right people where it could be helpful, but not withhold therapy. And I think this is where a treatment like delvocitinib cream is going to fall, something that people can really start using almost immediately. And it's something that is going to allow them to not have to sit around waiting for diagnostics that still could be helpful, but they just practically may not be able to get as well. And hopefully it'll also alleviate individuals' needs to move to a systemic therapy, something that's going to work from the inside out. As I know, a lot of patients that might have isolated disease of the hands or the hands and feet are not super jazzed about some of the risk-benefit trade-offs that come from using a pill or an injection. That is my last slide. So what I'll do is let me take my slides down just so you guys can stare at me alone like that. I think I left us with plenty of time to deal with some of these questions. Love to take any discussion points that Ali has as well. Let's get cracking, shall we? So I think I saw some stuff come through the chat. But Ali, anything that you want to add before we jump into the audience questions?
First of all, thank you for that presentation. And yeah, we've kind of compiled a lot of the questions, so you don't even have to worry about going in to dig into those. So starting off with, someone said, my daughter's atopic dermatitis has mostly subsided and it's only flaring seasonally, but the hand and foot eczema has been problematic. Is it common for AD to go into remission even when hand and foot eczema gets worse?
Yeah. So, hand and foot eczema, and again, better described in hands, is very common the older we get, just given all of the other stuff that's in our life on top of atopic dermatitis. When you're younger, you don't worry as much about irritant contact dermatitis because, you're at home, you go to school, you hang out, there's not much other stuff you're doing, right? But like as you get older, there's just more complexity in your environment. So atopic dermatitis as a disease itself waxes and wanes and can come and go. And it's not unusual for individuals to find that they have more persistent disease in some of these sites where there's just a lot more exposure, water, friction, pressure. And thus the atopic dermatitis may not have ever really gone away. It might just be focally involved in those areas. But I would surmise that there's probably more than just AD there alone. And so the short answer to the question is that's not unusual. That's actually very common.
Okay, thanks. Okay, and then we have someone asking specifically about the fissures on the hands and feet and the pain. So they said tempted to use liquid bandage to cover the fissures, but not sure if that's a good idea. What are your thoughts? What can I do short term to get immediate pain relief? And what kind of things would you recommend for that short term, like for if you do have to do the dishes or if you do have to cook, like short term, what would you recommend?
Yep. So short term, if you're going to do any wet work, anything whatsoever, gloves, please. Like, I know my patients say they're going to do it and sometimes they follow through. Sometimes it's hard. You end up doing your stuff. Gloves for sure as you're healing and you have active disease. Now, in terms of fissures, liquid bandage, completely reasonable. Anything with cyanoacrylates, so basically crazy glue or super glue, you probably have heard that before. If you haven't, it's not crazy. I promise you. My patients look at me like I've grown a second head or something like that. It's actually commonly what dermatologists will recommend. Those types of derma bonding agents are what's used actually for wound healing anyway in surgical specialties. They just have slightly fancier formulations, but that is not an unreasonable thing to fill that gap to allow the skin time to heal. It's usually going to granulate from the bottom up, and then it's going to repair itself. So you're not poisoning your hands or anything like that if you were to use liquid bandage, super glue, or something like that in those areas.
Okay, great. And then, so for someone's talking about, I know you kind of went through how kind of you said heterogeneous this disease is and how many different causes there can be. But for a patient at home, is there really any way for them to tell the difference? Someone said they've previously had eczema and AD and dyshydrotic eczema, and now they have this kind of eczema on their hands. Is there any way for a patient simply to tell at home what the difference is, or is it really only you have to go see a specialist?
I would recommend seeing a specialist, and I would say even then they may not be able to parse it out either. So being diagnosed with dyshydrotic eczema, we're sort of pushing back against as a terminology. It's a better to describe it by its manifestation. It's acute vesicular or recurrent hand eczema, and it is one of the spectrum of manifestations of eczema on the hands, probably not a separate disease category. And going back to the original point, atopic dermatitis totally could be the primary driver, but it's oftentimes not. And from big registry studies, largely out of Germany, they've suggested that the majority of people usually have at least one other thing driving it beyond just AD.
Okay, All right, and then we have, how can I choose a soap that won't irritate or cause a flare in my hands and feet? Do you have any specific brands that you recommend? Or let's maybe, if you can't do that, ingredients that are
Yeah.
good.
So I'd say that the simple binary choice is things that are non-soap based cleansers, right? And so when people tell you about soaps, they're usually talking about surfactants, things like sodium lauryl sulfate and others that make our bar soaps all sudsy and nice and make you feel clean once you've washed them off. The classic example everybody uses is Irish Spring, right? Like wonderful smelling soap, super soapy. When you wash it off, you feel totally dry and soap free. But the problem is that most of those chemicals do a really good job of stripping off lipids on the outer layer of the skin. And the more and more you do that, the more you're probably compromising your skin, especially if it's more prone to getting eczema. And so what we usually recommend are non-soap based cleansers. And so a really good rule of thumb is thinking about a lot of the cleansers that we use for atopic dermatitis and chronic eczema itself. So I can mention some brands. It's fine. I'll be agnostic. Your CeraVes, Cetaphils, Vanicreams, Avenos, Aquaphors of the world. All of them do make body and face washes typically that are formulated for people, quote unquote, with eczema. These products have the ENIA seal of approval on them as well, too. And you can generally be assured that these are not using traditional soaps and traditional surfactants. So the big difference is they're not going to smell as awesome. Two, they're not going to leave you feeling like totally dry and like you got all the soap off. There'll still be like this feeling of it almost being a little slippery. And that's just because of the chemical. They're also not going to suds the way that typical soaps are as well. But if somebody does have chronic hand eczema, I try to tell them to think about taking their favorite eczema-oriented wash plus their favorite eczema-oriented moisturizer, putting it in a small container, or just keeping big bottles around their house at all the sinks. And every time they wash their hands, pat it dry, put the moisturizer on, and just remind yourself to do that. So if there's 20 times a day you have to do it, it's going to be 20 times you're using your specific cleanser, and 20 times a day you're going to be using your specific moisturizer. Crazy, but even that can actually help push you in the right direction in terms of your disease without any pharmacologic intervention.
Okay, and then on that too, so is there, what are, maybe you can call out some of the specific differences between how you would care for hand and foot eczema versus eczema in other parts of your body, like without prescription, so just your kind of daily care, what are the specific things that would be different between those?
Yeah, so for the feet, the one big thing is that avoiding this idea of keeping your feet in moisture all the time, right? So feet are a really common place where people can sweat a lot. So just simply making sure that if you do sweat frequently, that would be frequent sock changes, maybe even an additional absorbent outer layer on that, rotating through your shoes. And when you don't have to be in your socks and shoes, letting your foot breathe, as silly as that sounds, because again, that is the major precipitant for individuals just having an environment where there's a lot of maceration and heat and moisture and occlusion. In the case of hands, the simple stuff is really just avoiding putting the kitchen sink on your hands, right? So a lot of times people, okay, have this moisturizer, they have alcohol-based hand sanitizer, they have their wash they're going to use. There's a lot of wet dry cycles. You might be doing work in your garage, work on your car, work around your house, work in your house. Wear gloves, protect yourself, and then definitely be really conscious about every time you have to wash your hands, using the right cleanser, using the right moisturizer. At nighttime, doing that soak and smear method is actually helpful in both hands and feet. So when I say that, what do I mean? Soaking your hands or feet maybe in a little bit of just kind of tap slightly warm water for 5 to 10 minutes, patting them dry, really covering them heavily with Aquaphor, petrolatum, Vanicream ointment, anything like that, and then putting a layer of cotton glove or cotton sock or something on the outside. And then you could even put an additional layer should you choose if you want to, but that'll not only help to build that barrier back up, but also won't make your bed a mess as well in terms of your sheets.
Okay, and then someone is asking about if you can comment on the use of glycerin as an ingredient for hand eczema.
Yeah, I mean, not specific data one way or the other, but glycerin is a common component that is found in many of the different over-the-counter moisturizers and cleansers as well too. It has humectant properties in terms of drawing in moisture as well to the hands. Glycerin technically is developed from vegetable products and things like that as well, so it has its relative naturalness too. Not something I'm specifically opposed to. Usually your main problems when it comes to OTC products are going to be stuff that has traditional soaps, stuff that has a lot of preservatives, chemicals, and fragrances as well.
Okay. And then, yeah, just going back to someone asked if there's any suggestions for a 2-year-old with hand eczema. So I guess more specifically, from everything that you've said, is there anything you would change for like little kiddos that have hand and foot eczema, or would it pretty much be the same?
Yeah, probably pretty much the same. I'd say that for little kids that have eczema on the hands, we start to think a little bit more about atopic dermatitis, more so than maybe sort of truly allergic or irritant contact derm. And if that is the case, that does open up the spectrum of medications potentially that are approved for atopic dermatitis, especially if it's involving other areas of the body. But pretty much all the recommendations that I made are consistent across ages. It's just usually little kids aren't washing their hands quite as much. And so that type of specific recommendation at that age may not be super practical, but definitely trying to keep that area well lubed up is important.
So yeah, so you listed obviously a ton of like contact and irritant, kind of triggers for hand eczema. It's a lot probably for a patient or caregiver to sort of like process that information. I'm wondering if there's sort of a one thing that someone can remove first, or is there like a biggest impact thing that or is it just unique per person?
Yeah, I think as we've learned in a lot of these NIA things, it ends up being pretty unique for person, doesn't it? So I would say that aside from the discussion that we've had about moisture and wet dry cycles, maybe that's the biggest place to start. The more wet dry cycles that you expose your hands and feet to, the higher rate and chances that you're developing chronic eczema. And so really trying to limit that to only as needed. And then if you're going to be in a place where you have to do that, simply wearing something to protect yourself, that's oftentimes even more powerful than thinking about a specific ingredient.
Okay, great. So someone's asking, if you have foot eczema, do you also, or like, if you have foot eczema, will you get hand eczema and vice versa? Like, is one like really linked to getting the other?
Yeah, not specifically. So people can have very particular involvement of one body part versus the other. Let's give you an example. Somebody that is in construction work that is wearing sort of big boots and going to be socks on their feet and probably quite sweaty all day would have very different risk factors for foot than maybe sort of somebody that is just working out at the gym intermittently or something like that, versus somebody that's working in a factory that deals a lot with industrial solvents, or someone that's working in the custodial industry where they have to use a lot of different soaps and stuff versus their feet. So I think the biggest difference is going to be environmental risk factors, and that's sometimes doesn't mean that just because you have one, you're going to have the other. But by virtue of just having eczema, your risk of having more eczema is higher than somebody that doesn't have any. So while relatively the answer would be yes, specifically, it's probably a lot more environmental.
Okay. Someone is saying that they tried mometasone, I think that's how you say it, for their hand eczema, and it improved greatly. Can you comment on the difference or advisability of mometasone compared to other corticosteroids, a medium?
Yep. Yeah, mometasone is one of several dozen topical steroids we have out there. I would say that it's probably quite similar to one that maybe more people are familiar with in the case of triamcinolone. So we think about this type of topical steroid as being medium heading towards strong, but not in the ultra strong category for topical steroids. Very appropriate for hands and very appropriate for feet. What you'll find is that your dermatologist may be recommending topical steroids that are actually on the stronger end for both hands and feet. And part of that is because the skin thickness is so much more on the palmar and plantar surfaces that while usually people may be talking about avoiding class 1 and class 2, or what we call our strong or potent topical corticosteroids on other parts of the body, we oftentimes have to go a little stronger for the hands and feet. So I don't have anything specific about mometasone other than if it worked for you, fantastic. But it just refers to maybe the fact that let's make a fake scale here. On a scale of 1 to 10 of steroid potency, it's probably hanging out around a 7, maybe a 6 or 7.
Okay. And then talked a little bit about like treatments and just kind of like in your clinical practice, do you see patients hand and foot eczema improving when they're taking medications, especially systemic medications for their atopic dermatitis? And then following up, someone asked specifically about what you think about Nemluvio.
Yeah. So in terms of the broadness of the question, yes. So we oftentimes have to go a systemic route to help people that they've gone to very strong topical steroids and it's just not helping. And you can definitely see people that do better and others where it's just kind of eh. And for the people that it probably goes back to what I said, that atopic dermatitis is one of several things probably going on in these body areas. So if people that are really good responders, it's probably atopic dermatitis in general that is driving most of it. Now, for your question about nemolizumab, it's one of our newer approved biologic therapies for atopic dermatitis. There isn't specific data for the hands at this point in time. I'm thinking to my use outside of the trial setting in the real world. I've definitely had people with more limited disease. It's a really great drug for itch. And so I've had people that have more neurodermatitis symptoms, particularly one person I'm thinking of on the hands, and they did pretty well. And so I think that much like the other disease, much like the other treatments I mentioned, if somebody has atopic dermatitis as their major driver and that's a reasonable therapeutic option, definitely one of several things to consider.
Okay. And then we have someone asking about a specific ingredient, phenodiethanol. Is that something that's in, they say that it's, they did a prick test for it and it's in a lot of recommended creams for atopic dermatitis, and they were irritated by it. So is there any suggestions?
Yeah, I mean, I guess if it's a prick test that you did, that's a little different than a patch test. And so maybe I can't sort of speak to exactly which one it was. But if there is an ingredient that specifically is coming up, usually on patch testing, you do the best you can to try to go through a safe list and generate what is okay. And I know that a lot of topical medications are formulated similarly, and sometimes it's very difficult to find something without it. If that truly is the case, then sometimes I have patients that have to bump up to a systemic therapy that otherwise would not necessarily be going that direction because they don't have many other choices. And so that is a consideration as well. In terms of the specific question about that ingredient, and when it comes to contact testing and or allergy testing, every person has a very individual profile. And part of the challenge is figuring out if that was even, how do I put it? If that positive reaction is actually specific to this scenario or not. A lot of things can turn positive, but if they may not be irrelevant, right? And if that is irrelevant, then maybe you still can use stuff, but maybe it is relevant, and that's only something someone's seeing you could answer.
Yeah. Okay. And then in your practice, I just like, and hopefully to give people listening some like hope around the, obviously there's, you talked about the mental health burden of hand eczema and how difficult it can be. In your practice, do you generally find that you can get people to be clear, almost clear, once you try the right treatment for them?
Yeah, for sure. So I'd say that when it comes to the hands and the feet, like every other body area, if you find a combination of things that works, then it's totally possible to get clear. I think the challenge is that with hands, there's repetitive challenges on a day-to-day basis, and there's probably a lot more influence of the outside world in addition to what's going on in your skin that's driving disease. So sometimes it can truly be difficult to eliminate everything that could potentially be driving the condition. And so it's the reason why, even with really good medications, sometimes people feel like they still have some degree of symptomology. And so it's one of the reasons why I'm actually pretty excited about delgocitinib cream as a treatment, because it's actually targeted but appropriately broad. And it does seem to work across, we'll get nerdy for a second, multiple T cell pathways that are important for irritant dermatitis, contact dermatitis of the allergic type, atopic dermatitis, even contact urticaria as well. And so it might end up being a really important treatment in our armamentarium that is appropriately safe and broad to help deal with people who have a lot of things going on.
Okay. And I don't remember if you mentioned this when you were talking about delgocitinib, but in the clinical trials, how fast was that working for people?
Yeah, so there was results seen within a few weeks for people. Like most of these studies, oftentimes it's not the entire population level, but you were seeing a separation pretty early on. The primary endpoint for these studies was around week 16, but part of the difficulty interpretability is they designed a scale that was really hard to like get a really good number on, because even trace pinkness, which I'm sure if Allie held up her hands right now, there's trace pinkness on them, means that you have active hand eczema. And so it was actually a really hard scale to do well on. So even with that, it did well. And for those of you that were listening closely, I mentioned that there is a oral medication approved in the rest of the world for chronic hand eczema, alitretinoin, that we don't have in the US for a variety of reasons. They actually did a head-to-head of this cream and that oral medication, and the cream was multifold better than the oral medication. It's rare that you'll ever see a cream go head-to-head with a systemic medication, and it was way safer with way less side effects too.
And then just one last quick question before we close out, but is there kind of been progress on the kind of clinical guidelines around hand eczema in the US? Because I know in some other countries it's a bit more established of what exactly it is and isn't. And I think you kind of talked through how many different things can be a part of hand eczema. Is there hope for those guidelines being more clear for the US coming soon?
Yeah, so that was honestly one of the reasons why when my fellows and I were chit-chatting about stuff to work on, we were thinking about how can we make this practically a little more understandable. And we were hoping this would get more people talking about what we should be doing and shouldn't be doing for most patients to get them to treatment faster. There's a few groups working on this. I'm part of one of them, and I think there's a couple of others as well that have been trying to put forward some practical guidelines and just general yardstick for how we should go about chronic hand eczema. There isn't necessarily a formal effort from the AAD at this point in time, and those guidelines take a really long time to get going. And by the time they get published, they're always out of date. Everyone here can speak to that from the atopic dermatitis sense, given that we go like a decade in between guidelines. So I'm not sure if that's the right body to do it, but I think that you'll be seeing a couple of papers coming out over the course of the next, let's say, 6 to 9 months that are trying to make an effort for how we should be thinking about and approaching the disease from a US perspective.
Great. Well, I think that's all we had time for. So thank you again to Dr. Chovatiya for helping us get a better understanding of hand and foot eczema. And if you want to find out more just from me in general, go to nationaleczema.org. And you can also, I think we'll have someone put in the chat if you want to register for the next webinar. And yeah, we'll see you next time.